All right, let's begin. Thank you for joining us. I'm Philip Johnston. I go by PJ. I am a product leader here at Pinnacle 21. First, we'll start with some housekeeping notes. If during this broadcast you have any questions or comments, please use the chat feature. It's on the right-hand side of the application. We will try to get through as many of the questions at the end of the session. Typically, there are hundreds, and we don't get to cover all of them. That's totally okay. We will respond to them in a follow-up blog post or we'll reach out to you individually to answer your specific questions over email. We're also going to post the slides and the recording of this afterwards on our blog. And if you would like to contact us directly, the final slide will show our email addresses so that you can stay in touch. Today is the start of a very special series. As part of the Certara Data Sciences platform, Pinnacle 21 is proud to begin the work of breaking down some of the silos within the industry. So this is a series where we're going to focus on cross-divisional or cross-team collaboration within the pharmaceutical industry. Today, we have Trevor Standish, who's going to begin the topic by focusing on some of the handoffs and the cross-divisional impacts between those who produce SDTM datasets and those who consume them in the form of medical writing. I'll hand this over to Trevor Standish now to introduce himself. Trevor, over to you.
Thank you, PJ. Hi, my name is Trevor Standish. I'm a product leader here at Certara. And today we're going to talk about SDTM handoffs. So we're going to cover the interactions between biostatistics and medical writing, utilizing SDTM data in order to write patient narratives. The first thing we wanted to cover in our session is the role that data plays between these two groups of biostats and med writing. And the use case we're really focusing on is the use of SDTM data between these two groups. To start, we're going to cover a high level about the roles of these two groups in case you're not in one. So the first group, biostatistics, you could think about this group as a team that's in charge of curating the data for a study. They need to ensure that the data is compiled in a standard format, such as SDTM, and they need to ensure that the data adheres to standards such as CDISC. These individuals use the P21 Enterprise app quite heavily to help in this effort. The second group is medical writing. So this group is in charge of curating documents for the study. They need to ensure that the content is written correctly and matches the outcomes that is realized in the SDTM files. And they need to ensure that these outcomes adhere to standards, whether in the company or standards like ICH. And these individuals use the writer application quite heavily. So both groups actually do a lot of similar activities. However, each of them use different sources, use different types of applications, and are really striving, again, to document both from a data and a document perspective the outcomes of these clinical trials to help accelerate submissions. When it comes to the SDTM and patient narratives, we've really observed two types of interactions between these two groups. It really varies based on your team size and how your organization sees the responsibility falling within the two groups. But just generally speaking, these types of relationships cover 80 to 90% of what we see at various organizations. So the first relationship is where biostatistics is in charge of producing the patient narratives. Often in this case, they're using some tool or macros, and oftentimes the medical writing team is then receiving these documents to be able to perform QC and a review. The second relationship is where actually medical writers are producing the patient narratives. Oftentimes, biostats will actually provide a patient profile or a listing to these medical writers, and then they're actually having to copy and paste from these files to author this patient narrative. We see this relationship where medical writing these documents to make up the lion's share of the examples, so 80-90%. And sometimes we've also seen this hybrid relationship in which biostats will be asked to produce individual patient level data sets, very similar to the patient profile or the patient listing. And again, medical writers are utilizing this to then refer to when they're authoring these documents. Ultimately, we see that there's two types of challenges, both data challenges and process challenges in these types of relationships that introduce kind of friction or inertia that slow things down. And it's really important to focus on when you're talking about accelerating submission timelines. So in these types of relationships, what we want to look at two areas, and it's both data and process. In both instances, there's actually data challenges that arise and there's process challenges as well. And this impacts work and ultimately slows down the timeline process for submissions. We want to start by talking about the data challenges. There's very nuanced challenges when working with these data sets. And we're not going to cover all challenges with it, but there's really 5 key areas which we find really slow down the process amongst both the biostats and medical writing teams. So the first challenge is making sure it's all there. Whenever you're transferring these types of documents or data sets from one team to another, you do want to account that for all the information. And it's super critical before the authoring begins, because if you change that data after it's been sent and the writing begins, it often can create a tremendous amount of rework. It's true both for the domains, the variables, and even specific values. And it really is important, especially for studies with long durations, where you might be working with pre-database lock data. In this traditional writing scenario, where, again, patient profiles or data is being sent to the medical writing team to author, you want to make sure that it's all there so that it really prohibits or stops the teams from having to do rework. The second challenge is really inconsistencies. And this occurs very often, actually, and it's really especially true for studies with long durations. The biggest thing is if there's a new query on the data, things like changing in the variable name or in the format if it's coming over in a patient profile, or if there's even new variables introduced based on a change in the protocol. These can be really hard to keep track of, especially when you're authoring these patient narratives. And it especially is true for omitted values, these inconsistencies. So making sure that the data fields are produced and have everything present. So a great example is if you have a date with the month, the year, but you've omitted the actual day. That's a perfect example that creeps up in data a lot of the time with those inconsistencies. The third one is consistent interpretation. Again, when you're working with these larger teams with both biostats and medical writing, ensuring that the data from team to team is interpreted consistently across the team members. Anytime you don't have that collective interpretation that's consistent, you introduce the risk of misinterpretation. And that's really especially true when you're using abbreviations for certain variables. Versus the more friendly term that people are more comfortable with. And so this happens a lot of the time because the communication happens outside or separate of the data set, meaning I can't select a specific value, let's say, and alert my team member that, hey, I have a question about this specific value. And so anytime you're using like a chat or an email, there's the possibility of an inconsistent interpretation. The fourth challenge is really around formatting. And so the simplest thing you can think of is having fields that are all uppercase or lowercase or mix. You often see fields that have hyphens versus some do not. A great example we think about is if you have a data field, data variable, we've seen it where sometimes that there's different entry points where there's 17 different formats of how that date is presented in the data set. And so, a super simple, concrete example is where a date value is entered month, day versus it being entered day, month in another area. And that makes it very challenging in terms of interpreting data and ensuring consistency. And so formatting is very important. And then the fifth one is lack of traceability. So having no traceability between a document for a writer. And so when you could think about this, like we have traceability from the source data set to our SDTM files, but then that traceability breaks down from the SDTM data sets to the documents themselves. And this becomes very time consuming when you're not only writing, but when you're QCing the documents, because you then need to go find the source of a specific value, let's say a dosage date or any kind of value. and it really slows down the team in the authoring process. So again, there's 5 main data challenges: making sure it's all there, inconsistencies, making sure you have consistent interpretation, formatting challenges, and then lack of traceability. The other big challenge is process challenges. So on top of the data challenges, process challenges exist when we're utilizing these SDTM data sets to write these patient narratives. And we're going to talk about it from the perspective of the relationship. So the first one, if you remember, the relationship one is where Biostats is in charge of producing these patient narratives. Oftentimes, these groups have little medical writing experience, and oftentimes they're not writing in a way which actually resonates with the end reader, which is the point of these documents. And we see that often the language used struggles to highlight relevance of certain outcomes. In addition to this, we find there's styling inconsistencies. Sometimes these documents do not follow company or writing standards such as ICH. And so what it creates is a time delay in which medical writers are having to spend that quality QC time to review and make a lot of changes to those source documents that are coming from biostatistics. And this really increases overall cycle time quite substantially, and it becomes quite time intensive. So again, the purpose is we're trying to accelerate submission timelines, and this is a suboptimal scenario. The second relationship, and that's the one in which medical writing is writing these patient narratives. Again, there's some struggles here as well. With this one, they're less familiar with data, these teams, and so sometimes they can write in a way which resonates with the end reader. However, making sure that data is interpreted correctly is always a challenge. Oftentimes, if there's patient profiles or data sets provided to these teams, they're more or less one-off data files, so specific for the study. And so it offers very little scalability, and it really results in a large degree of manual authoring or copy and paste, which is really how it's been done for the last 20 years. The big challenge here is you can't work pre-database lock oftentimes because you need to rewrite the entire patient narrative or re-QC the entire document if there's data that changes. And that's because there's lack of traceability. So again, this is another one, suboptimal, very time-intensive relationship. And I think we see that across the board with both scenarios. So to recap, we have data challenges and we have process challenges when utilizing SDTM data to produce these patient narratives. And it's really a suboptimal process for most teams and most organizations. It really means that in this instance, it's actually slowing down the submission process. And we're really looking for ways in which teams can actually accelerate that process. Before we get into look at any kind of solutions or what people are doing now, we want to talk about what people have tried historically. And so historically, this is a challenge that's been present, and organizations and teams have tried to overcome this in a couple different ways. And again, this is not universal, but these are the most common we see. The first solution that teams have tried is just outsource with more people, more or less. What this means is more biostatisticians or more medical writers. And the whole notion there is more means that we can make things faster and it will be better. This often results in failure because you create large consistency problems. Most of the time, there's a lack of traceability between these data sets and these patient narratives. This also results in no internal ownership, and it's more of a short-term fix that creeps up every time you have a new study that you need to produce these patient narratives. And so what happens is organizations are constantly fighting this battle of cost and quality every time a new study arises in which this needs to happen. The second solution that people try that we see is a little newer, and there's a couple options out there, is what we call these black box engines, in which you're actually sending data into, setting it up, and then producing these documents from. Sometimes teams will also use macros, depending on what application you're using, to help this as well. But the challenges here is there's usually a large upfront setup, so they pick 1, 2, 3 different studies. They configure them based on that study. And what happens is once those documents are produced, those patient narratives, there's little control over presentation. And so writers and teams are having to go behind and do a lot of cleanup. These engines are often rigid, meaning they were really good for those 1 or 2 studies. But now that is generating, your 4th, 5th, or studies downstream. They're very hard to adapt on a study-by-study basis. And so, it creates a lot of cleanup and rewrite on the back end. And also, teams who are QCing these documents, they don't have traceability back to those source SDTM files. And so they're having to dig through profiles or data sets to find these, and it actually increases the review QC time quite substantially. And the big thing in terms of scalability is when we're talking about these engines or macros is that they really don't scale elsewhere, meaning that you can't use that for a protocol or a clinical study report. So these engines are really tailored to those patient narratives, and then you can't really expand that elsewhere in the organization. So we find this alternative solution people have tried. It's overall, at best, an incremental gain and benefit to the organization. Before we start talking about what teams are doing to overcome these data and process challenges, we want to pause and look at what we mean and look at some tangible examples. So at the beginning of the webinar, we talked about how Biostats was using the P21 Enterprise a lot and how medical writing was using the Writer app a lot. And so we want to come back to this and look at an example, a tangible example on our screen to see how a writer would utilize the software to write a patient narrative and in real time and what they're doing today. And then we can talk about how this is overcoming those data challenges and how it's overcoming those process challenges. In the software, as you can see, it's displaying the information for the text along with the domains and variables. And what I'm going to do is create a presentation, a preview of this live data. And so in this case, we have one which is finished. And when the team utilizes the software, all the things you write and create are saved off into your own proprietary library. We've referred to it sometimes as forever writing, as you'll never need to write this demographic section again. So what we're going to do is try to recreate what we see at the top. And so in this case, we're going to pull in some of the fields just by drag and drop and refresh what this looks like. So as you see here, we added patient, their subject ID, and the age. And down here, we have this appearing. And this would look the same, not only for this subject, but also any subsequent subject that we were to preview. So you can look through and spot check on the various patients on how they look. Now, a few others we have an option for is, let me go ahead and select this field. We have a lot of different options, and so we're just giving you a flavor for what you could do. This is a one that is very commonly used, setting if statements. So in this example, what we want to do is any time that the F appears, we want it to say female. And you can do this not only for this particular field, but really for any that comes up. We see this used for a lot of time for unknown values in the data set. And so you can put in standard language around that. So we're going to save it, refresh it. And as you see here, it's updated for this particular patient, but it's also updated for all of our patients here that are in question for this particular study. And now, when we go ahead and produce these files, not only do we have traceability for this particular patient, but for this particular variable and this particular domain as well. Another one we could look at is tables. And so this is a previously created table. It's a labs table, so they tend to be on the larger side of things in which it has a lot more information. But what you can do is, because you have the ability to pull in all sorts of different things that you would expect, you can add in a table like this and then simply take the value you want and drag and drop into it. As an example here, I can jump down, we'll save it, refresh our preview, and then what will happen is it will update and we can preview in real time. It's really nice because then This is essentially allowing you to type out documents for a patient narrative, but also at the same time is it's creating in-text or appendice tables, depending on where you want to use them. You're completely in control, you being in control of what that final presentation looks like. What you're going to notice is the first one at the top is a list, but here, now it's repeating over and over again for all the concomitant medications. What you can do is, because you have full control over the presentation, you can actually change this to a list. And what this does is you're able to make it so you don't display duplicates. You can customize the separator, see an example, and if it looks good, apply it. Again, we'll save, refresh the preview. And then you see here, it's starting to look a lot like it looks like above. New technology is allowing these teams to really redefine the way they work, and it's creating a new type of relationship that wasn't available before. So both Biostats and Med Writing can use the software. This really depends on where the responsibility to produce patient narratives falls within your organization. Most organizations are leaning towards medical writing to produce the patient narratives using the Writer app. And this is actually elevating the collective team's knowledge, both in the Biostats and Medical Writing, to understand the CDISC standards, to understand those domains, and to understand those variable names. And so it's creating this communication bridge in which there's a shorthand, or you can really start referring to like variables or this common knowledge, and it's helping foster collaboration, but also ultimately accelerating those submission timelines. So just like we talked about having data challenges and process challenges, we want to talk about how there's data successes and process successes as well. Again, having this new way of working really allows for things to change in a way which is better for the team. And so for the data successes, we really see three major things that stand out amongst teams utilizing this. It is actually allowing teams to have full traceability from data collection to SDTM files all the way through the document. That level of traceability was just not possible before. And it allows teams to take those data sets from P21 Enterprise and go directly to the Writer app. When data appears in the document, it becomes very clear exactly where that source data comes from and how that presentation looks like. The second of the data successes is actually automating this process utilizing those SDTM files. And so teams have a lot of ways to modify presentation. It doesn't allow them to, it really eliminates the need to create listings and patient profiles. And so you can go straight from those SDTM files into the Writer app. And you can do things like change data table layouts. You can look at field filters. You can change data formatting, all those things we looked at a moment ago in the demo. And the third major success for the data is that you can actually use SDTM draft data, so pre-database lock, to create the patient narratives. That was something that was not possible before. And what's really interesting is that this was an organic outcome that we saw amongst teams, is that as soon as you create that first SDTM data set and put it into Enterprise, you obviously want to check to make sure that it adheres to those CDISC standards and you have a good validation score. But once you're able to do that, you can push it straight to the Writer interface to see what it looks like. And before you have database lock, you can actually utilize that to make sure that you're not missing anything, improve quality, and have that as feedback either to your data management or biostats. And just like we have in Enterprise, that you can refresh those SDTM files, you can also refresh the SDTM files in Writer so that you can automatically update all those patient narratives in real time. Just like the data successes, we're also seeing process successes amongst teams. So there's this alternative way of working, and teams are reimagining what they're doing to make the work easier and more efficient ultimately. The first one is because medical writing is really being responsible for producing these patient narratives, it's actually allowing biostats to utilize their time more efficiently and giving time back to them. And that's a huge time savings for the team. Once those SDTM files are created, whether it be final or draft, these, again, can be pushed straight to the team. They don't need to create patient-level data sets or patient profiles, and they can preview the outcomes in real time, in minutes, really, just like we saw in our demo. The other one is utilizing the P21 validation engine. We're seeing a higher degree of compliance to those CDISC standards, and that's really helping the medical writing team downstream, and it saves a lot of time. One of the things is these medical writing teams are often providing feedback to the biostats team, and that's also then giving more feedback in how to improve the data. Another one is project timelines are really shrinking and collapsing. And so because the process is becoming simplified, it's eliminating a lot of redundant work by the team. For example, before, often biostats would have to produce those patient-level data sets or patient profiles, and oftentimes those are no longer being created whatsoever. And so they don't need to validate those files. They don't need to validate those data sets. They don't need to review them because they just are no longer needed. And so in this, the outcomes are becoming more predictable in timelines because we know that as soon as we can create those data files, those domains for the SDTM, we can also begin that authoring process. And that's really giving teams and organizations a competitive advantage we're seeing. Another one is that teams are actually collaborating on documents and sections. So because these tools are integrated, they now have a medium in which they can review things in real time and make changes and transitions from those structured data sets to unstructured documents in a very seamless way. And I think the big one is that revisions have really collapsed in terms of taking seconds now, and it used to take minutes or even days, weeks, and months. But it's in part because of the collaboration amongst the teams, but also the fact that you can QC data points and patient narratives in real time, since you have that live preview, and immediately talk to the colleagues, whether it be in medical writing and biostats, about questions on the data or things that need to be improved if it's pre-database lock. And having that ability to cascade across a multitude, essentially all the patient narratives, really saves a tremendous amount of time amongst the team. So reducing data needs while automating the writing in these patient narratives is really leaving more time to be strategic. The organic outcome is a lot more collaboration among both biostats and med writing, but also the ability to write with pre-database lock and seeing what that looks like way before the study is even concluded. So in today's webinar, we talked about the SDTM handoffs, that interaction between biostatistics and medical writing, utilizing that SDTM data to produce patient narratives. And since we have a little bit of time at the end, we do want to open it up for questions. So please feel free to post questions in the chat. Okay, we have a few questions coming in. The first one, does this work with existing studies and existing studies in P21 Enterprise? So yes, you can utilize both new and existing studies. So as long as you have the SDTM data sets, just like you loaded in Enterprise, you can also load that into Writer. So you can push it at any point, like we talked about, both draft and finalized data. So if you're looking to do upcoming studies or try out this for some legacy studies, you can do both. Okay, another one, a couple questions coming in is, how do I learn the software? How does our team, get up to speed on using the Writer product? So at Certara, we offer training. We also have customer support. We have materials like creating presentations for patient narratives and guides on how to do that. We also have a guide on building a template in the software from like an old Word template. So a lot of organizations have legacy Word files or Word templates, those standards we talked about. And we have a guide on how to transition that to use in Writer. Okay, so there's a question about where can you also use the Writer interface. So in today's webinar, we talked about using the app to produce those patient narratives utilizing the SDTM files. The application also supports other types of documents, so things like clinical study reports, SDTM reviewer's guide, data transfer agreement, things like that. So we'll also have subsequent webinars covering those topics. If you want to know more in the meantime, you can just send us a message, and we'd be happy to follow up and cover off on those other documents as well. That is about all we have time for today. Again, we hope this was helpful in terms of making it clearer the interactions between biostats and med writing using these SDTM files to produce patient narratives. Again, my name is Trevor Standish. I'm one of the product leaders here at Certara, and thank you for attending.